Good morning and thank you. Now, if you're seeing this video, then I must be having trouble connecting to the conference, so I already owe you an apology. But who knows, this might turn out better than if I was trying to do it live. I want to thank you for taking a truly precious half Saturday to join us, time that might have been spent outdoors with family, enjoying our wonderful homeland instead of being connected to yet another Zoom session. I appreciate that you're taking time to learn more about how we can do better, how we can be better at taking care of each other, ourselves, our families, our friends, our neighbors, our coworkers, and our entire community. Now, I've been asked to speak about local health inequities today, and I want to first of all say that today's talk will be focused on racial inequities in health. I realize that there are lots of other axes of inequity, but today we're going to be focused on race. So let's start talking by examining what we mean by inequity. Now, Oxford Dictionary defines inequity as a lack of fairness or justice, so that's a start. And I like this widely cited definition by Margaret Whitehead from 1992. Health inequities are health differences that are avoidable, unnecessary, and unjust. So one more time, those three words: avoidable, unnecessary, and unjust. And if we take a second, we can think about the last 15 months and wonder how much of the health outcome differences that we have lived through and are still living through, how much of this was avoidable, unnecessary, and unjust? The differences, that is. Okay, I'm going to flip back and start sharing my screen. Give me just a second. Here we go. Okay. So yes, it's true that I have no financial disclosures to make, but I do have some disclosures. I'm not an expert in this area. I have no formal training in public health, and I did not collect or author the data I'll be presenting. There are people virtually present today who are far more knowledgeable about this data than I am. And on your screen, you see a partial list of some of the people and groups who deserve all the credit for this information and for bringing this story home to Whatcom and Skagit counties. I want to thank them and thank all of their teams for this important work. Particularly, I want to thank Rachel Lucy, Director of Community Health for Peace Health, Ariel Furtado, ARNP, and Erica Gadzig, Dr. Erica Gadzig, my colleagues at North Sound Family Medicine, part of Family Care Network, who have organized this CME. So since it's a talk about inequity, I think it's worth taking a moment before we get to the data part of this talk to examine how it is that I'm the person talking with you this morning. If, as I just said, I'm not neither the collector nor the author of this data, why am I the speaker? Is it because I'm a doctor? Is it because I'm male, older, a person of color? Does it increase attendance to have an older male doctor present rather than a younger female expert who is not a physician? You know, the contributors that you see on the acknowledgement slide are almost all women, and this entire CME has been organized by these three very dedicated women who have put in many hours of their own time, and yet our speakers are predominantly male. I realize these are uncomfortable topics and may seem off topic for CME, but I want to acknowledge that injustice can take many forms. And here's another thought about the data itself. Data drives decision-making, or at least we hope it does. But data itself can be a source of misguidance because bias can be built into how the data is collected, how questions are asked, and what questions are asked. The data we choose to collect often reflects our view of what might matter. But that said, I believe the data I'll show you today. I believe in it. I believe it's good. It's not perfect. It's a good start. It's important, and it's powerful. So I did agree to speak on this topic today, and here's why. The work of eliminating healthcare disparities, the work of eliminating health inequity is important. It needs to get done. And when I said I would support this work, this was my assignment. I think of myself as a foot soldier in this campaign, and today my job is to present and amplify this information and amplify the voices of the individuals and organizations doing the real work. And the other reason is because this is my home. And over these years, my patients and my colleagues have taught me that change, even really hard change, is possible. And so I'm hopeful. Now, if we do our jobs well today, the next 4 hours will be filled with lots of information and emotion. So I'm going to borrow a phrase from my daughter who uses this when teaching challenging material. Please bring your best brain. Some of what we present may trigger strong emotions, possibly negative emotions, fear, threat, resentment, anger, possibly loss. And when we're in this state, we're not as capable of being open, not as capable of seeing, hearing, and feeling. We're not as creative. So I sometimes use this acronym RAIN for these moments, especially when I'm feeling targeted myself by the information. 1 breath for each step. R for recognize what you are experiencing. A for allow the experience, turn towards it with openness. I should say often the first 2 steps are sufficient to de-escalate my brain and I'll just move on. But if I need to continue, I'll go on with I for inquiry, which is gentle and non-judgmental. Some people might use the term leaning in for this. And N is for non-identification, which is recognizing that you and the experience you're having are not one and the same. And I want to thank Mindfulness Northwest for teaching me this tool. Okay, with that, let's look at some of the data. Many of you know that April the 8th, 2021, Dr. Rochelle Walensky, the director of the CDC, declared racism a serious public health threat. And she cited not only the disparate impact that COVID-19 is having on minority populations, but also that the way COVID-19 is playing out is just one more manifestation of a much more chronic problem. I'll read from her announcement. Quote, the data show that racial and ethnic minority groups across the United States experience higher rates of illness and death across a wide range of health conditions, including diabetes, hypertension, obesity, asthma, and heart disease when compared to their white counterparts. And additionally, the life expectancy of non-Hispanic Black Americans is 4 years lower than that of white Americans. 4 years. So let's remember that because it comes up later. And I just want to point out that these conditions, diabetes, hypertension, obesity, asthma, heart disease, these are common. These are what we see in our offices every day. So these are big disparities. Now, COVID-19 is on all of our minds. So let's look at the national COVID-19 data. This is from the National Institute for Healthcare Management. I'm not going to read it all to you, but I know that some people may be calling in and working off small screens and not able to see the slides well. So I'll summarize. The thing that gets me about this data is how unsurprising it is. So minorities, American Indians, Alaska Natives, Latinos, Black Americans are experiencing 2.9 to 3.6 times the rate of hospitalizations and 1.2 to 1.5 times the rate of death compared to white Americans. These are large magnitude effects. Now let's look at the data closer to home. This is from Washington State. Here you can see that the Latinx population is disproportionately burdened with COVID-19 infection, about 2.3 times the average case rate and 1.7 times the hospitalization rate, which mirrors the national data. So essentially what I've done is I've just turned these numbers into factors. In Skagit County, the Latinx population has carried far more than their share of the COVID-19 burden, despite being only 18% of the total. When I did a little math, I added up that in 1 8-month period from March through October of last year, the Latinx population in Skagit County had over half of all cases in Skagit County, even though they're only 18% of the total population. In Whatcom County, I don't have a similar slide, and there's a caveat that 21% of the cases reported in Whatcom County don't have known ethnicity or race attached to them. But the COVID infection rate in the Hispanic population in Whatcom County was 3.1 times that of the white population, and it was 4.2 times higher in the Alaska Native and American Indian population. So let's back up a moment and take a look at the basic demographics. So this is Whatcom on the left, Skagit on the right, total population at the top, and then races down the left and their percentages. This isn't going to surprise anyone, but we are predominantly white counties. The percentage identifying as Hispanic or Latino is substantially higher in Skagit, 18% versus 10% in Whatcom. Black is 1% in both counties. American Indian, Alaska Native, 3% in both counties. Asian, 5% in Whatcom, 3% in Skagit. Less than 1% Native Hawaiian and other Pacific Islander, and 4% are multiracial. I'll just point out that these numbers don't all add up to 100%, and that's because the Hispanic population that designation is also attributed over other racial groups. So it adds up to more than 100%. Now, if we look at where the disparities come from, that means if we look at where we start, we need to start with our children. So here's a slide of kindergarten readiness. This is 2017, 2018, so this is pre-COVID data. I'd like to point out 3 things here. The racial group with the highest rate of school readiness is the white population, but that rate's only 54%. Wouldn't it be better if 100% of our kids were actually ready to go to school when they started? The percentage of kids ready for school drops down to 44% for multiracial families, 27% for Hispanic families, 23% for the Alaska Native American Indian population. So again, this is pre-COVID data. And because of small numbers, the Black student population is not represented here. And you'll see that some populations drop out when the numbers are small. Now, we know that this metric, kindergarten readiness, relates to much longer term outcomes in education, in health, in substance use, in economic outcomes, criminal justice. So let's just pause and let this sink in. These kids are 4 to 5 years old, 4 to 5 years old. And they're already getting sorted into tracks that will have lifetime profound impacts. Now, did these children make bad choices by the time they're 5 years old so that they deserve this? Do they start pulling themselves up by their own, do they need to start pulling themselves up by their own bootstraps at age 4? Or maybe we should ask ourselves, is this avoidable? Is it unnecessary? And is it unjust? So let's move on to 10th grade. This is a 10th grade report from Whatcom County from 2018. Again, this is pre-COVID. And this is about depression symptoms. So four things to call out here. This is not formally diagnosed depression. So this is an affirmative response to a screening question. Second thing, the overall rate is concerning to me because for the best performing racial groups, it's still 27% in the lowest reporting group. And that's the Asian group. Black, Hispanic, white, and multi-ethnic are all between mid-30s to mid-40%. And the rate in the Alaska Native American Indian population is 66% at 10th grade. So 66% of the Alaska Native American Indian population, 10th grade, reporting a positive response to a screening question for depression. And once again, look at the magnitude of these differences. These are big effects, much larger than we often see in a lot of other areas of medical research. So let's move on another 2 years to graduation time. So graduation rates, this is another surrogate marker for long-term safety, health, and prosperity. And don't all of our children deserve a fair shot at that? Again, we see concerning differences in racial groups, with white and Asian students at a substantial advantage compared to multiracial, Hispanic, and American Indian and Alaska Native students. Black students are not represented here because of small absolute numbers, which does raise some questions for me. And on the positive side, though, the magnitude of the disparities here have narrowed since kindergarten. And so I think that's a thank you to our schools and teachers for doing that work. Now, once you graduate, it's time to get out in the world and make a living. So here's the Whatcom County median household income data. And we already know that income has a strong effect on many aspects of health and access to health. So these numbers pretty much speak for themselves. Again, this is pre-COVID data, rounding to the nearest thousand. The incomes range from 59K in Asian families to 55 in white families, 41,000 for Hispanic families, 32 for multi-ethnic families, and American Indian Alaska Native families, just under that for Native Hawaiian and Pacific Islanders, and 24,000 for Black families, which is well under half of the Whatcom County average. Here is the Skagit data. Similar trends Note a smaller degree of disparity between groups, which I think would merit some investigation. But still, if you look at the disparity for the Black population versus the average, it's still very substantial. Now, moving back to a strictly health outcome, here's life expectancy at birth, and this is Skagit County first now. In Skagit County, the life expectancy at birth for the Black population is on par with the white. The American Indian and Alaska Native population and the Pacific Islander populations are at an 8 to 9 year disadvantage. And the Asian and Hispanic populations have a 4 to 7 year advantage, respectively. Remember back at the beginning, Dr. Walensky reported a 4-year difference for the Black American population nationwide. We're looking at a much larger difference here. In Whatcom County, we have even wider disparities. The Asian and Hispanic populations have switched positions, although they still have a relative advantage. In Whatcom, the Black population is at a 5.8 year disadvantage compared to the white population, whereas they were on par in Skagit. And the American Indian Alaska Native population is at a 12.1 year disadvantage, 12.1 years compared to the white population. And the Pacific Islander population fits between the American Indian Alaska Native and the Black population. Here's another way to look at the life expectancy data. This is in terms of years of life lost at 65. So these numbers are for Skagit, and they're normed to a population of 100,000. I don't know the details of the big spikes in 2016 and 2017, but these are relatively small populations, so these types of perturbations of the data are to be expected. But you can see the consistent trend towards the Alaska Native American Indian population and the Pacific Islander populations sustaining thousands of years of potential life lost. In Skagit, that's consistent with the life expectancy data. The white, Black, Asian, and Hispanic populations cluster fairly close together. Now, Whatcom County, these are similar numbers, note slightly different year spread, 2011 to 2017 versus 2014 to 2019. So, but similar idea on the data. These are also normed to 100,000 population. The differences here are that the Black population in Whatcom County is losing more years of life than in Skagit. So they're the second bar. And here the Asian and Pacific Islander populations have been combined, so that may be masking some effects. But the overall message is the same. Thousands of years of life, thousands of years of potential life lost, and large and ongoing disparities by race. So I hope I've given you a fair sampling of the available data on local healthcare disparities. I know this takes some time to digest, so this information will be available to you for follow-up, and there's a lot more information available. The literature on healthcare disparities and health inequity is deep, it's wide and long, and overall it's pretty consistent. The problem is real, it's big, and it is here. Now, I know I presented you with numbers, but these are not just numbers. Every excess year of life lost is a person taken from our community too soon. These numbers have faces, names, relationships, and community. These losses diminish all of us. So thank you for listening. I appreciate the opportunity to speak today. You know, I can't see you, so I have no idea how this presentation has landed with you. You may be skeptical of the entire premise that racism impacts health in America. You may be concerned and unsure how to proceed. You may be committed and frustrated. You may be angry. You may be enraged. You may be heartbroken and worn. You may be all of these things. So I'm going to borrow and paraphrase some language that I first heard at the Congregational Church on Cornwall. No matter who you are or where you are on this journey, there is a place for you in this work. Now, I know it's been a tough 15 months, and maybe you're tapped out, and I get that. You know, sometimes taking care of yourself is the best start. You may hear a knock on the door, and you know you can't answer it right now, but the next time you hear that same knocking, you'll know what it's about. But maybe you do have a little energy and curiosity left over. So here are two things that have helped me. Sometimes pausing and taking stock can be useful. Learning to look around and see the advantages that one has, and then figuring out how to dismantle and give away some of that can be eye-opening. And I got a quote from my second daughter, my younger daughter, that has stuck with me. She said, "The unit of justice is relationship. And sometimes being silent a moment longer than normal can open the way to a more full experience of another human. And so maybe that can lead us towards some justice." And then just today, because she knew I was nervous about this talk, she sent me this quote from the Talmud. "Do not be daunted by the enormity of the world's grief. Do justly now, love mercy now, walk humbly now. You are not obligated to complete the work, but neither are you free to abandon it." And I want to emphasize humbly, because this is difficult work and it's really inevitable that we are going to get things wrong along the way. But I think humility and persistence will get us along the way. So thank you very much.